The topic is male external genital organs. So we should know what are the external male genital organs and what are the internal male genital organs. So external male genital organs include the penis and the contents of the scrotum, namely the epididymis, the vas deferens and the testes. So this is the head of epididymis, body of epididymis, tail of epididymis, and this is the location of testes. The epididymis continues as the vas deferens and a part of it lies in the scrotum. So the penis, testes, epididymis and part of vas deferens in the scrotum, they constitute the male external genital organs, while the internal genital organs include the rest of the vas deferens, the seminal vesicle, the ejaculatory duct, the prostate gland and the bulbourethral gland. So students, you must know what are the male external genital organs and what are the male internal genital organs. So today's class focuses on the male external genital organs. So we start with the penis. So it has got a root which comprises of two erectile masses called the crus, which are attached to the pubic arch, and a central part which is called the bulb, which rests on the perineal membrane, and this bulb has got the urethra. The bulb continues in the body of penis as the corpus spongiosum, while the crura continue into the body of penis as the corpora cavernosa. Then this portion is called the glans of the body of penis, which is the conical terminal part of the body of penis, and here we can see the opening of the external urethral meatus. Now this is sagittal section showing parts of penis. Now here we can see the different structures. We can see the urethra as it is passing. This is intrabulbar fossa and the urethra is coming here to open on the exterior aspect. Another dilatation here is called the navicular fossa. Now coverings of body of penis, they include the skin. This is thin skin and is retractile over the glans. Superficial fascia of penis is devoid of fat. Deep fascia, it does not extend into the glans penis. Now one competency is anatomical basis of phimosis and circumcision. So what is phimosis? Normally the foreskin is retractable. So in phimosis, the foreskin is tight and cannot be retracted over the glans penis. It is often a congenital condition associated with a pinhole meatus. So the treatment of this condition is circumcision. And what is circumcision? Circumcision is defined as surgical removal of foreskin by giving a dorsal slit in foreskin. So normally, by up to 3 years of age, the foreskin is adherent to the glans. After that, it should become retractable by age 6. So if till age 7 the foreskin is not retractable, then it can cause problems for the boy, and circumcision may be advised. And what is circumcision? Surgical removal of foreskin by giving a dorsal slit in the foreskin. Next we come to the blood supply of the penis. So this is showing you the transverse section of the body of penis, and we can make out the different arteries: superficial dorsal artery, deep dorsal artery, superficial dorsal vein, deep dorsal vein. One thing about the deep dorsal vein you should know is that this passes anterior to the perineal membrane, and this ultimately communicates with the prostatic venous plexus. We can make out the superficial fascia here. We can make out the skin, superficial fascia, buccal fascia, the erectile masses. We can make out the location of the urethra. So transverse section of body of penis, one should know how to draw this diagram. Lymphatic drainage of penis, the glans that is drained by the deep lymph nodes, that is the lymph node of Cloquet, or Rosenmuller, while the rest of the penis that is drained by the superficial inguinal lymph nodes. So the glans penis is drained by the deep inguinal lymph nodes, lymph node of Cloquet or Rosenmuller. Next we come to the layers of scrotum. So skin is the outermost layer, then there is this subcutaneous muscle called the dartos muscle, which contracts in cold weather to thermoregulate the area so that the testis temperature is maintained for spermatogenesis. Then we have got the external spermatic fascia, which is a continuation of external oblique aponeurosis, cremasteric fascia, which is a continuation of internal oblique muscle, and then we have got the internal spermatic fascia, which is a continuation of fascia transversalis. So the thing to understand here is that one should know the layers of the scrotum, and that external spermatic fascia is a continuation of external oblique, cremasteric of internal oblique, internal spermatic fascia of fascia transversalis, and one should also realize that transversus abdominis is giving no continuation in the scrotum. And these are the layers of scrotum. And the dartos muscle, this is supplied by the genital branch of genitofemoral nerve. So this diagram also, students, you should know. Nerve supply of scrotum. Anterior 1/3 of scrotum is supplied by segment L1 of spinal cord, while the posterior 2/3 of scrotum is supplied by segment S3 of spinal cord. There is a ventral axial line separating the two regions. The region supplied by spinal segment L1, the nerves involved are ilioinguinal nerve and genital branch of genitofemoral nerve, and by S3 the nerves are the perineal branch of posterior cutaneous nerve of thigh and the posterior scrotal branches of the pudendal nerve. So nerve supply of scrotum one should also know. Now left testis is lower normally compared to the right testis because the left spermatic cord is longer than the right spermatic cord. The testis has got an upper pole, lower pole, lateral surface, medial surface, anterior border, posterior border, and the thing you should know is that the epididymis lies along the posterolateral aspect of the testes. So this is the location of the epididymis. Now this is tunica vaginalis, that is the remaining portion of the processus vaginalis, which is forming a covering around the testes. An extension of tunica vaginalis takes place in relation to the epididymis, and this is known as sinus of epididymis. So the coverings of testes are tunica vaginalis, tunica albuginea, which is a white fibrous tissue. This tunica albuginea forms a mediastinum testis here, from which septa, they divide the substance of testes into different lobules. There are around 300 lobules in the human testes. So this diagram of transverse section of testes also one should know. So tunica vaginalis is the outermost layer, tunica albuginea is the inner layer. So this is the region of tunica albuginea, and the innermost layer lining the lobules is vascular and is called tunica vasculosa. So these are the layers of the testes. One can appreciate here the head of epididymis, body and tail of epididymis. The epididymis functions as a reservoir of spermatozoa, and then this tail continues as the vas deferens. So this is the longitudinal section of the testes with the tunica vaginalis, tunica albuginea and tunica vasculosa. Now we know that the testes has a temperature of 3 to 4 degrees lower than the abdomen, and this temperature is required for spermatogenesis. Now this temperature is lower than the abdomen because of the presence of pampiniform plexus of veins. These veins take up the heat from the testicular artery, and this maintains the temperature of the testes. But what happens when this mechanism is called countercurrent mechanism of taking up heat from the testicular artery. But what happens when the veins themselves are tortuous, enlarged and dilated? So when the pampiniform plexus of veins itself is tortuous, enlarged and dilated, the condition is called varicocele, and this is more common on the left side. So why varicocele has a high incidence of 95% on the left side? There are various reasons for that. So 8 reasons have been described. Let us see how much we can cover. One important reason is that the left renal vein that is clamped it in between the abdominal aorta and the superior mesenteric artery arising from the abdominal aorta. So when the person stands erect, the pressure of the loops of intestine from above, it pushes the superior mesenteric artery over the left renal vein, and the left renal vein is liable to compression. So this results in varicocele on the left hand side. Then other reasons are also there. The left testicular vein is opening into the left renal vein at a right angle, while the right testicular vein is opening directly into inferior vena cava at an acute angle. So this also favors the occurrence of varicocele on the left side. The left testicular vein is longer than the right testicular vein. The walls of left testicular vein are less competent compared to the walls of right testicular vein. The left suprarenal vein, it opens into the left renal vein from above, and so the adrenaline rich fluid that acts at the entry point of left testicular vein and causes spasm in this area. So this also results in varicocele incidence higher on the left hand side. The left testicular vein is closer to the kidney compared to the right testicular vein, so it is more liable to be compressed by kidney tumors. The left testicular vein is also liable to be compressed by the sigmoid colon. So that also is a factor which increases the possibility of varicocele on the left hand side. So these are some of the factors which you should know, and um, you should express yourself when asked why varicocele incidence is higher on the left side compared to the right side. Now, what is hydrocele? Hydrocele is collection of fluid in the tunica vaginalis. Now, tunica vaginalis is the persistent process, a part of the processus vaginalis. So, tunica vaginalis has got two layers, outer parietal, inner visceral. So, when the fluid collection is in the tunica cavity of the tunica vaginalis, that condition is called hydrocele. Now, it is of different types: vaginal hydrocele, which we have just described, that the fluid is restricted to the tunica vaginalis cavity. Congenital hydrocele, here the opening is there so that the fluid can enter into the peritoneal cavity. So the communication with the peritoneal cavity is there. The opening is just so much that fluid can communicate with the peritoneal cavity, but hernia does not take place. So this is the level of superficial inguinal ring, and this is the level of deep inguinal ring. So the communication with the peritoneal cavity of the fluid is there in case of congenital hydrocele, while in vaginal hydrocele the fluid is confined to the cavity of the tunica vaginalis. Then we have infantile hydrocele. Here the fluid extends up to the level of deep inguinal ring. And then we have hydrocele of the cord, where the persistent processus vaginalis is present in relation to the cord region only. So fluid is collected here in the region of the cord. So these are different types of hydrocele. Students, you should know about torsion of testes when the spermatic cord gets twisted, and the main function of testes is spermatogenesis. So it lies outside the abdominal cavity, so that the temperature requirement for spermatogenesis is possible. Spermatogenesis requires 3 to 4 degree lower temperature than the abdomen, and that regulation of temperature in the testes is done through two muscles: the cremasteric muscle, which can elevate the testes towards the abdomen, and the uh, this superficial muscle of the scrotum. So that can also help in thermoregulation by contraction, the dartos muscle we are talking about. So this was about the male external genital organs. Till the next time we meet, it's bye from my side. A gentle reminder that you can go through whatever I've told you. You can read the text by visiting the site www.busdesire.com, and there you can find my online book with this ISBN number, and you can go through the text. Thank you for your time, and thank you for your cooperation.